So what is the approach to history taking with that context of what is neurology and what we will be doing for the next 7 weeks? The really essential approach of neurology is to obtain or establish during the history on who is it that has having a problem, all details, the gender, the handedness, the chief complaint, what exactly is it that is wrong with that person, and when did it started and how it has progressed. And all of that information is obtained because it will lead to determination of where is the lesion, which is the localization in neurology, what part of the nervous system, why is that lesion, which is the pathophysiology, why that they have developed this lesion, and then how are you going to approach it. So to answer where is the lesion, why is the lesion, and how is the lesion, you have to go through who is the patient, what exactly is wrong in extensive details, and exactly when all these problems have started and progressed and how have they progressed. So I will show you again these 4 steps of neurological history, but we will approach this through doing some questions. But these are the 4 steps. Number 1, when a patient is presenting with neurological complaint, what exactly is not right, what action is not right, and in what way. And that's often less clear than what you might think is obvious. So for example, a patient may present with dizziness, but many things can be called as dizziness. Dizziness may be lightheadedness, dizziness may be vertigo, dizziness may be difficulty walking, incoordination, ataxia. All of that may be called as dizziness by the patient. And you know probably more than I do that patients often have very, very vague term for exact problem they're having. So to elicit what exactly do they mean by their complaint is very important. What exactly do they mean by what is wrong with them? So if they say, oh, I cannot walk, what do they mean? Is it the coordination? Is it the weakness? Is it jerk? Is it tremor? Is it twitching? Is it vertigo, dizziness? Why cannot they walk, right? So it cannot be, oh, the patient has problem walking. That is not an acceptable chief complaint. That means that you have not yet elicited what exactly is wrong with them. So what action is not right and how it is not right is a chief complaint in good details. And you cannot just say, oh, patient has trouble walking or trouble speaking. That's just a start. And now you have to exactly elicit how is it not right? What exactly is wrong with walking or speaking? And that leads you to the next question, which is onset. When exactly did it start? Did it start acutely, subacutely, and chronically? And we'll address that. And how has it progressed since it started? So if it started 2 days ago, has it remained the same? Was it worse in the beginning and now better? Was it better in the beginning and slowly gotten worse, or suddenly gotten worse, and so on and so forth? So these are the 4 very important components that will help you later on elicit what is the lesion and why that lesion might have happened. So let's look at some of these details through questions. So because of the short of time, I'm not going to wait to have you answer the questions for me, but feel free to answer it in the chat box if you would like. But let me review the question for you. So a 33-year-old male is presenting with onset of weakness in the right side for 2 hours. He was playing football with his son at home and noticed right leg being heavy and had trouble getting to the chair and grabbing it with his right arm. While in ER now, he reports being much better and able to walk around. And what is the pattern of patient presentation? So that's the first question, although there are many other important things at this stem. The very first question is that, what would you call this onset that happened 2 hours ago and patient is now better? Was it acute? Was it a subacute, chronic progressive, or subacute progressive? And the answer is acute. And let me show you some of these definitions. We sometimes use hyperacute, something that happens instantaneous, although this is kind of a mixed term. Not everybody uses this term, but often vascular, like strokes or bleed, will present hyperacute suddenly with a flip of a second. So in that sense, you can actually use hyperacute as the onset for this patient. But more commonly, we will label someone like him as acute with onset between minutes to an hour. So it took a few minutes to realize what is going on, and that is what is called acute. If someone suddenly collapses, you can call it hyperacute. But if someone like him who has problem with the leg, he walks around, grabs a chair, sits down, it takes a few minutes to do it, you will call it acute, not hyperacute. And often the onsets of acute are from vascular or epileptic or metabolic etiologies. Subacute will be that takes hours to establish. So it started 6 hours ago, was fine for the first few hours, then gradually got worse. And now he's really bad after 6 hours or 8 hours or 12 hours or after 2 days. That will be a subacute presentation. Infections often present subacutely over 2-3 days, or inflammation or sometimes toxicities. Subacute to chronic will be something that takes weeks to establish. So patients started noticing problem 3 weeks ago, and now they're presenting because it's gotten so bad. So it took 3 weeks to become this bad at presentation, and that will be either nutritional, endocrine, toxic, and sometimes even metabolic. And then chronic is something that is going on for months, either stable, either slightly progressive, or non-progressive. So it doesn't have to be always progressive chronic. It could be non-progressive or stable chronic or static chronic, but it has been going on for months. And degenerative diseases classically present in this kind of a chronic pattern of presentation. So this is onset. Let's look at the other question, which is the trajectory. So 72-year-old male who presents with family with complaints of difficulty with memory. Family reports problem first noticed intermittently 2 to 3 years ago, but has gradually gotten worse, and now they're worried about leaving him home by himself. What is the trajectory of this patient? So not the onset. So acute and progressive, or subacute or recurrent, chronic and static, chronic and progressive, subacute and transient. And of course, it cannot be subacute and transient because the problems are still there. It could be chronic and it's not static, but it is progressive. But it could be subacute recurrent, meaning the problem is coming and going, and it could be acute progressive. In an acute progressive situation, let's look at some of the definitions a little bit more. In an acute progressive trajectory, the progression is bad within days. So if someone had an acute onset, which was, in minutes and hours, they were bad, and then they continue to progress or decline after that, then acute progressive will be in the hospital within a day or two and will not take 2 years or 3 years for the family to bring him. So that means it has to be something chronic, stable for a while, and very slowly progressive underneath or on top of it or intermittently. Now, there could be a subacute recurrent pattern that could be something similar. But in the recurrent or relapsing pattern, you have to have patient go back to close to normal in between the episodes. An episode may be weeks, episodes may be months, but in between the episodes, the patient went back to a normal self for you to call it a relapsing phenomena or recurrent phenomena. Because there is no evidence this patient ever became normal since they started 2-3 years ago, then chronic progressive will be more appropriate trajectory for this patient's presentation. And here are some of the examples of etiologies. What will present as static, as progressive, as transient, as recurrent or paroxysmal, and fluctuating. And of course, in recurrent and fluctuating categories, do not forget inflammatory causes, inflammatory diseases, most famous being multiple sclerosis. All right, so these were the 4 steps. And then here's a very important tip to remember, that anytime you have obtained the 4 components of neurological complaint, always ask the patient, is there anything else that I've not asked about that you want to add, or is there anything else you would like to add to this? Because the history is obtained so complex, and a lot of time we end up with direct questioning. The patient will not answer if you don't ask for it, and you may forget to ask, or it may not make sense for you to ask. It was so rare or random that the patient will not tell it, because they're answering your questions. So they're waiting for you to ask the question, and you never ask that question. So always ask this kind of an open, vague question for patient to jump in and add something, or the family, that they may not have done it until at this point, before you close your neurological history. So this is history. As I mentioned, there will be some more handouts. So I have a very detailed handout of all these 4 questions on what actions to ask and what to do as a reading assignment in your course, if you're part of the certificate track. And you will complete the reading assignment, listen to all those details from Dr. Deesing, Scott Deesing, who came up with this WAT method, and you will answer an assignment as part of your reading assignment. Let's switch quickly to the examination, and I will start with my mentor, Dr. Zabad, always started with, which is proper instrument. It is important to have proper instrument, no matter what setting you're in, if you are going to see patients who have neurological complaint. You cannot say, because I'm not a neurologist, I don't need to have a good hammer or a good tuning fork. If you're going to have a good stethoscope, you're not a cardiologist either, then you should have a good hammer and a good tuning fork. You should have some tongue blades, some pins or equivalent to check for pinprick or something. You don't have to use it on every single patient. That's not the point. But anytime someone is coming up with a neurological complaint like numbness in the leg, you are expected to have pins available with you so that you can check their pinprick and sensory examination, and so on and so forth. Stethoscope is part of a neurological examination, although we don't use it very often. And then vision card. Most people underappreciate how useful a vision card could be in a neurological examination. So they are very easily and cheaply available. A lot of time, these drug reps will often find them for you, or even a company will print it. It doesn't matter what logo or brand it has on it. All right. So after that, let's go to the basic principles of examination. And these are basic principles that were defined by my mentor, Professor John Bertoni. And he says that always think of examination as a fact-finding mission. And this is important to remember because you do not want your preconceived notion about what is wrong with the patient make you not see or ignore an important examination finding. Of course, traditionally we say that examination is done to verify what the differential that you have made in your history, but examination is also a part where you could actually pick up something that you may have missed on the history completely. So always be very objective and document what you are seeing. And even if it doesn't make sense to you, do not be blind to it. Write it down and maybe it will start making sense to you later on. Touch all the bases and we will mention what those bases are, and only do more if it is necessary because of course time is short and life is short. So this is the basis of neurological examination that you should touch even slightly. So, touch means that you just should do at least one or two things in that 5 bases, and it doesn't have to be or the whole complete examination. The base 1 is mental status examination, which includes speech and language. The base 2 is cranial nerve examination, has a separate place, although it comes from a very small part of the brain, but it is very significant and useful. The base 3 will be sensory examination, especially it is relevant. It is very important to do. Otherwise, because it's very objective and patient dependent, you can even skip it. The base 4 is motor examination. And base 5 will be gait and coordination. So these are the 5 bases, and you will find these basic explanation of a neurological examination anywhere. You can Google it, you can find it on YouTube. I also have a 5-minute neuro examination video on YouTube that you're welcome to go and have a look at. And I will give you a quick examination of these 5 bases on what is the minimum basic examination. And I will have some more details in our certification course as some of those videos to watch in our workshop with residents, how we teach those examination, how to do reflexes and so on and so forth. The reflexes we consider part of coordination and gait or motor, it's your choice, but that is part of those bases. So these are the 5 bases you should touch whenever you're doing a neurological examination. So this is a helpful documentation and a reminder sheet. So this is page 1 and on the left is page 2. This is prepared again by my mentor, Professor John Bertoni, who have taught neurological examination for 35 years to more than 100,000 people. And he has really nailed it down. And he is the one doing the 5-minute neuro exam in the YouTube video, by the way. And you will find, if you're part of the certificate course, this is available in the course as something you can download and print and keep it as a reminder, or make copies and just document the exam over here. And again, it's touching through those bases, the minimum mental status examination, olfaction, the cranial nerve examination, the 2 to 10, including one which became important in COVID. The motor examination, the common movements that we check, not muscles, we check movements, and each movement may be caused by more than one muscle. And then the gait and coordination, the sensory exam and reflexes, which is part of either motor or gait examination, whichever way you want to think about it. As I mentioned, that there is 5-minute neuro exam video where Professor Bertoni is doing that exam. You can find it on my YouTube channel. You can find other neurological examination and neurological questions. These days, I'm reviewing a lot of MCQs for my students. You can find over there as you go through the neurology rotation, and you're welcome to do that. And then there are more detailed neurological examination course that I have prepared is available that you can find on Merit Academy. This is my favorite book for neurological examination. It is very comprehensive. It's 350 pages or something like that. So I don't expect all of you to read it, but if you are not sure on how or what maneuver to do, you can have this one. Is called Techniques of Neurological Examination. It's by Dr. DeMeyer, and it's not very expensive, especially in Pakistan. You can find cheap copies, but you should have it. And anytime you need a question, you have a question, you can go back to it and look in this book for that question. All right, let's look at some of these components of neurological examination and talk about some of the tips and tricks. So I'm not going to review the whole exam, but I thought I'll just quickly go through some of the tips or challenge part of the examination as question. So pupil response, when doing an alternative swinging flashlight test, so where you flash a light in one eye, swing it to the other eye, then swing it back to the same eye, then swing it to the other eye. So when you're doing this swinging flashlight test for pupils on the patient, which of the following is abnormal, considering that you're testing the right eye? So you start with the right eye, you test the right eye of the patient, and swing it to the left, then back to the right, then back to the left, then back to the right. What of the following pattern will be abnormal? Pupil constrict when the light is moved back to the test eye. pupil constrict when the light is moved to the other non-test eye, pupil dilate or pupil dilate, and so on and so forth. So let's look at it. Let's see what exactly is a swinging torch test and what will be considered abnormal in the swinging test. So this is a baseline, eyes in the dark, where the eyes are slightly dilated on both sides. Right eye is where the light is being flashed first. And when the eye receives the light, the eye pupil will constrict and the retina has to receive the light, right? So there should not be any cataract. There should be no blindness. Retina is functioning. And there is appreciation of right now. But not only the right eye constrict, the left eye also constrict, even though it is not getting the light, because the retina on the right outside of the eye also have connection to the other side of the brain. So the left eye will also constrict, which is a normal phenomena. And when you move the light to the other eye, the light will as you're moving the light, it will start to dilate, but as soon as the light hits that eye again, it will constrict again. And usually the constriction direct from the light in that eye is slightly more than the indirect constriction, but it could be closely equal. So as long as the eyes remain constricted as you swing between one eye to the eye, that is a normal phenomenon. However, if that left eye, his blindness, cannot appreciate the light, so when the light comes from the right normal eye to the left abnormal eye, the eye would dilate. And if the eye dilates, that means that the eye did not get the light once the light torch came to this eye. And not only this eye dilates, the other eye dilates too. And then when you go back to the normal eye, both eyes constrict again. So the constriction of the eye is a normal phenomena, no matter where the light is, and dilation of the eye is an abnormal phenomena, no matter where the light is. And that is what is being tested in this swinging torch light reflex. Let's look at another question. So this is a 52-year-old male who presents with onset of double vision. He reports some mild headaches that have been ongoing for a few months, but have become worse lately. And for last 2 weeks, he was noticing difficulty looking to the left and getting blurry vision that progresses to now having double vision in all direction except when looking to the right. So this is a subacute progressive, right? Subacute onset 2 weeks ago, but it's progressive, it's slowly getting worse. Presentation in 52-year-old with headache and double vision. Well, initially blurred vision and now became double. And this is your examination of the eye and what are the 4 abnormalities that you see on this patient. I'll give you a few seconds to think about it, and then I'll start explaining in the interest of time. So the 4 problems that are visible in this patient is that number 1, right eye is down and out. And the way you can tell is if you look at the mid-pupillary point and you draw a line straight, then the mid-pupillary line on the other eye is higher than the mid-pupillary line on this eye. Now, is the left one, which is higher, abnormal, or the right one, which is down and abnormal? And that will depend on the rest of the finding, right? But let's, for sake of discussion, say right eye is down and out. And out, you can tell easily that the white of the conjunctiva, bulbar conjunctiva, or sclera, is equal on the left eye, but white is far more on the left side of the right eye and far less on the right eye, which means the right eye is looking out. So it's not only down, it's also out, and now it's more likely to be this one to be abnormal. There is also ptosis on the right eye. So the eyelid normal position is that it's almost 1/3 to midway between the top of the pupil and top of the cornea. So it's usually 1/3 or halfway between marks. So it does definitely clear the cornea, the pupil. When the eyelid is touching or covering part of the pupil, that is ptosis. It's always an abnormal eyelid. It cannot be a normal eyelid. The right frontalis muscle is activated and you see increase on the side, and that is likely a compensatory problem that the frontalis is being activated to lift that eyelid which is down. Without this frontalis activation, the eyelid will go down even more. That is a compensatory phenomena, and that's why the right eyebrow is also lifted up. They're trying to activate frontalis as a compensation for levator palpebrae superioris to try to lift that eyelid. And then right pupil is dilated. Now, we made last comment about which pupil is abnormal, because without knowing the light setting, you cannot say is the smaller pupil abnormal or the larger pupil abnormal, right? So the only way to decide which pupil is abnormal, the bigger one or the smaller one, you have to first decide which eye is abnormal, or you have to do a swinging torch light reflex to tell which pupil is abnormal. Is it the smaller one abnormal or the bigger one abnormal? So this is a third cranial nerve palsy. It is pupil non-sparing, people involving third cranial nerve palsy. I actually have a video on my YouTube discussing this specific topic, pupil sparing versus non-sparing third cranial nerve palsy, and I encourage you to go listen to it to give you an idea why these examinations are important. All right, let's look at this patient and see what is wrong with it. And if you listen to me on the last slide, you can already look at the pupil and the eyelid and tell something is not right. One pupil is definitely being cleared by the eyelid, while the other pupil is not cleared by the eyelid. And so that is clearly an eyelid droop. And now that pupil is smaller than the other pupil. And this time we're calling a smaller pupil as a problem. So there is meiosis, not mydriasis. So there is a constricted pupil on the abnormal side. It still look quite dilated because it's a dark room, likely. Look at the other pupil, how dilated that one is. And the eyelid is drooping, so it's likely a right Horner syndrome. Another question on facial on examination, 35-year-old male presents with headache for 1 week. He reports pain as sharp, excruciating pain that lasts for a few minutes and recurs frequently. Pain starts from top of the head and involves forehead and cheek on the right side and is associated with clenching of the teeth. What is the likely diagnosis? The likely diagnosis depends on which nerve is involved, and which nerve is involved is dependent on the distribution of the nerve. And if you know the anatomy of the distribution, the facial sensations are all covered by trigeminal nerve. He has problems starting on the top of his head, and that is to remind you that the V1, the trigeminal nerve, goes all the way up to the middle of the scalp or top of the head as the area covered by the trigeminal nerve. So forehead is part of it. So trigeminal nerve pain is called trigeminal neuralgia. It classically has an acute onset with remitting, relapsing, or recurrent pattern, just like this patient is having. So it's likely a trigeminal neuralgia. So this is a 22-year-old male who presents with onset of drooling. He says that last 2 days, he was noticing some numbness on the side of his face. And this morning, he noticed water spilling from the corner of his mouth, along with some slurred speech. He's very anxious and apprehensive as his father had stroke 3 months ago. And what test will you order for this evaluation? And that test that you will order will depend on what you think is the diagnosis. And this is his picture. And his picture will tell you which side is abnormal. And if you have been looking at it and thinking, the right side is abnormal because patient is asked to activate his facial muscle, and that's why he has left facial muscle activation, including pulling of the corner of the mouth, deep nasolabial fold, constriction around the eye, lifting of the eyebrow, and frontalis muscle activation. This is he is asked to do, and he is completely unable to do on the right side, and right side remains flat or paralyzed. And paralysis of the right side of the face with numbness and subacute onset, so with quick progression, is classic presentation of a Bell's palsy, seventh nerve palsy. Now, in seventh nerve palsy, you often do MRI of the brain, not just to rule out a stroke or demyelinating lesion in brainstem that can present as seventh nerve palsy, a Bell's palsy, but you also want to rule out any tumor in that area that is pressing on the seventh nerve and presenting as a seventh nerve palsy. And sometimes you can even see inflammation or swelling of the seventh nerve. Actually, almost 1/3 to half of the cases, if you do early MRI, you will see an inflammation of the seventh nerve, either in the bony canal or just before it enters the bony canal in a facial nerve palsy. But of course, it is not a stroke, and even no testing will be fine. And most traditional neurologists, general neurologists, will not do any workup on this patient for a week or more unless the patient continues to stay weak and do not improve, and that's when they might do it. But there is another syndrome. There is 4 Ramsay-Hunt syndrome, and one of the Ramsay-Hunt syndrome, I believe the third, is involvement of the herpes with seventh nerve, and that might also be a presentation of persistent seventh nerve palsy. And there is some other syndrome, rheumatological syndrome, which can give you a persistent seventh nerve palsy that is not improving. So seventh nerve that is not improving after 7 to 10 days, you should do an evaluation on what might be an alternate cause. And as I said, rarely strokes and inflammation brainstem can also present as seventh nerve palsy. Now, I also want to bring up that most places where you have testing, there is often the test starts with a scenario, and you have to first diagnose the scenario before you can answer the question, even though question is pharmacology or physiology or pathophysiology or next best step in management. But understanding the diagnosis is still the most important first step before you can answer that question. So which of the following examination tests will test for the function of seventh nerve in this patient? So if you decide to do an examination besides the face, facial muscle, what else will you do? Will you test for taste, hearing, jaw closure, swallowing, or tongue protrusion? And the answer is taste. The seventh nerve also carry fibers from the taste nucleus to also test for the taste on the tongue as part of it, and also lacrimation rides for the part of it on the seventh nerve before, I think, it leaves in the bony canal. All right, here's another question. Neck examination. So patient has neck weakness. To test the right cranial nerve 11, you should ask the patient to do what? So patient comes in, has a neck problem, has a weakness. You're trying to test the right 11th cranial nerve, right? 11th cranial nerve will innervate the right sternocleidomastoid and trapezius. And what you will ask to do, what will you do to test the right sternocleidomastoid? You will ask him to turn his head to the right, raise the shoulder on the left, turn the head to the left, stick his tongue out, or push the head back. And the answer is turn the head to the left, because sternocleidomastoid makes the head go opposite. So, and again, that is related to the visual field phenomena. And this is the right SCM will ask the head to turn to the left side. All right, motor testing. When you're examining a normal strength of a biceps, you pull on the patient's arm, and for the triceps, you push on the patient's arm. And why is this done? Why do you do differently to test biceps and triceps? Are you doing it to testing same muscle against each other? Are you convenience of examiner and patient? Are you doing it because other techniques can also be used? Or it is more comfortable to the patient? And the right answer is that you should, in upper extremity, test same muscle, same your muscle with patient's same muscle. So if you're testing patients' elbow flexion, which is called bicep, but it's more than biceps. But if you're testing elbow flexion, you should use your elbow flexion to fight against patient's elbow flexion. So you're testing your elbow flexion strength with the patient's elbow flexion strength. Similarly, if you're testing for elbow extension, you should use your elbow extension to test against patient's elbow extension. So you're always trying to match your strength with the patient to try to find that subtle difference of weakness, which will be 4 minus a 4. If he's completely paralyzed, we cannot lift it against gravity. It's obvious. It doesn't matter how you examine him. But if you're trying to find a 4 plus or a 5 minus or a very subtle weakness, then this comparison will be very important. And in most people, they should have strength close to your matching your strength with few exceptions. All right, a 33-year-old male presents with onset of weakness in the right side 2 hours ago. He was playing football with his son at home and noticed right leg being heavy and had trouble getting to the ER and grabbing it with his right arm. While in ER now, he reports being much better and able to walk around. When there is no obvious weakness in this patient, what test can you do to find out more subtle weakness in his upper limb? So remember, this is the same case we looked at earlier for the onset and progression. So the question is that if there is now normal strength according to him, and he has improved in 2 hours, but you want to be sure that he has improved 100% and not 90%. What test can you do to find out a subtle weakness in his upper limb? Okay, would it be sensory testing, reflex testing, pronator drift testing, lifting heavy weights, or tone and bulk exam? And the answer will be pronator drift test. So pronator drift is that with patient with a mild weakness, when you have them hands out supinated and they close their hand, the weak hand will slowly pronate and will also flex at the fingers and have a flexion at the elbow. And that is called pronator drift. There's actually a very good 2-minute audio podcast from American Academy of Neurology, which reviews the summary of the history of pronator drift. How was it identified and how it became a normal part of examination? It's by Dr. Bose, who is an official historian and head of the history committee, history of neurology committee in American Academy of Neurology. Very good podcast. I think it's called podcast Neurology Minute or something like that, if you listen to podcasts. All right, sensory testing. So when you're doing a sensory examination on the patient in the limb, we test the limb in the following sequence. We go from proximal to distal. Proximal here means hip. So going from up, down, or we go from distal to proximal, meaning that from toes up, we go from left to right. So we do the left first and then the right one. We do right to left, we do the right side first and then the left side. Or sensory examination is randomly done so that the patient cannot predict what you're going to do. What will be the right answer? And again, in interest of time, I'll keep going. The answer is distal to proximal, because 90% of the problems you're going to see in sensory issues will be a length-dependent neuropathy. And in a length-dependent neuropathy, the longest fibers are the ones that are damaged first. And if they have normal distal exam, they will have a normal proximal exam. And if you find a distal abnormality, then you slowly go back to see where that level is. And that is why it is called a glove stocking. So stocking, is a feet or socks, and gloves will be hand. Glove stocking lesion. And another important tidbit is that the length of the upper limb nerves is about equal to just below the knee for the lower extremity nerves. So often, if they have a stocking loss, which is below mid leg, they will not have any problem in their fingers in a length-dependent neuropathy, because the length of arm nerves are too short to be involved until it goes above the mid calf, usually around below knees, where you will see also finger involvement and hand involvement. Reflex testing. In order to get a good, reliable deep tendon reflex response while testing, what is the most important principle to keep in mind? A, joint has to be half bent. B, having a right reflex hammer. C, complete relaxation is achieved. D, perfect positioning of the patient. And E, brisk sudden tendon stretch is achieved. Now, all of these are important, right? And the question is most important principle. And the most important principle to remember in your mind is that a brisk sudden tendon stretch has to be achieved for a reflex to initiate. And most of the time when you do, you're not getting the reflex, this is a problem. And this can happen either that the joint is not bent properly, or you don't have a right reflex hammer, or you're not striking strong enough, you don't have a complete relaxation of the patient, or patient is not positioned right. But whatever the reason, the problem that you're having in all of those situations is that you are not able to cause a brisk sudden tendon stretch, which will create a reflex. Otherwise, it will not create a reflex if you don't do it. And that's where most of the people fail to get a reflex, and then the attending comes in and they can get a reflex. This is a proper reflex hammer tendon technique. The swing has to be really strong enough to create the sudden stretch. You have to have half bent joint. You have to have some way to localize the tendon that you will be striking to stretch it. And then, although this is a very light strike that Dr. Bertoni is doing, you have to have a good enough strike to say that the reflex is not present. So if the reflex is absent, you want to make sure that you did do a good strong strike before you called it as an absent reflex. Plantar reflex or Babinski is very important in neurology. Against Joseph Babinski, the important idea is to start with a minimal stimulus. It is a nociceptive reflex, but amount of nociception or pain needed is variable for patients. So you start with the lightest pain that you can give, and you gradually increase the amount of pain without causing any laceration on the foot of the patient to try to see if the Babinski reflex is present or absent. It is absent only when it goes down. Not absent doesn't mean that the toes did not do anything. 90% of the time, if the toes did not do anything, is because you did not elicit it right. So toes should either go down or go up. Going up is abnormal or positive, and going down is normal or absent. And not doing anything is called mute. And it should be only in severely neuropathic patient that the reflex is mute. So reflex being mute is not common.